consultant psychiatrist, Padma Hospital, Vijayawada, professor and head of DPSMC department, Chinnotpalli. I would request Dr. P. Krishnamohan sir to kindly come over to the dais and introduce us to the speaker.
And we are going to make it very simple because we are doing listening about the various new drug development areas in psychiatry. And this is one area which probably we did not expect till late 2010 onwards. This mechanism of action of this particular drug differs from other drugs which we had been using throughout our practice. Because now we are not targeting the receptor mechanisms, not the neurotransmitters. We are targeting something else that is there within the cell itself, the second messenger systems. And we are targeting mainly the phosphokinase enzymes. And the person who has exhaustively worked with this molecule, Endoxifen, Dr. Prasad Rao, is known to everybody. Usually he doesn't require any introduction. Just to tell a few words, he is like my younger brother. He is from the same college. His father was our principal, and he had done his DPM from NIMAS, and after that he did his MD from PGI Chandigarh. And since then he had been practicing in Hyderabad and built up a very big psychiatric kingdom there. And he is internationally known and is very ambitious. And he is trying to still achieve many more heights. Maybe I will see him one day as WPA president, hopefully. With this short introduction, it's over to Prasad Rao. Maybe after his talk, Krishnamohan will comment on that. Thank you.
Thank you. I contacted Karri Rama, whom I know him for probably the time when I entered into medical school. And before I go, I think I need to declare my conflicts of interest. I'm a clinician, I'm a researcher for the various companies. I've been involved in drug development for the last 3 decades. When I started my research quite early, and I'm a speaker for pharma. I hope my bias in these areas would not anyway affect today's lecture. I start with my namaskarams and gratitude to Rama Reddy garu, whom we all considered as a kind of a large mentor figure, both in private psychiatry and in psychiatry. We remember, I think, sir, in your morning lecture, you did talk about what you have done. You forgot to tell that even when we boarded our trains to Hyderabad, you gave us the tiffins to carry in this train. That would be his hospitality, and I had a personal relation with him, stayed with him for some time. And to keep on telling you Rama Reddy garu, then I don't have time, but I would consider that he is like a Ramaban. His name itself has Rama Reddy garu. His own approach in psychiatry and his own work for Hinduism in general, religion, spirituality and psychiatry, I think we all. And to the IPS Andhra Pradesh State Branch, the President, Secretary, who have given me the opportunity to consider me to talk here. Thank you very much. And my best wishes to my dear brother, IVL, who is going to lead the IPS State Branch for the year. I will start with this story. I would like to be a lion. When I want to write a medicine, the medicine should be like a lion attacking in the forest, our patient's illness. And the way I would like to go today is to first introduce very essentially the pharmacological treatment of bipolar disorders, and then come, as my dear chairperson Dr. Sudhakar said, what is this PKC pathways and psychiatric disorders? Endoxifen story in a very short, the original pathway of evidence, and then I will show you what I have done in the last 3 years of my multi-center study. Remember, in most of my talk you will see only evidence, and my dear friends Vishal, Krishna Mohan, and my chairperson Dr. Sudhakar will share in the end their own experience. The new horizons in bipolar mood disorder. Pharmacotherapy is the only treatment which is probably universally accepted. Psychosocial treatments are needed to promote the pharmacotherapy in a large way. But most important, in the last more than 3.5, 4 decades, we didn't have any new mood stabilizing molecules, but some of you might agree or disagree that atypicals, if at all, are anti-manic, but they are not mood stabilizing, or the evidence for mood stabilizing in this class of atypical antipsychotics, it's difficult. There are here and there evidences, for example, Olean's fluoxetine combination on one side, or a lamotrigine which is only has evidence and doesn't have evidence for bipolar depression, but has only prevention of depression. This is Bowden and Calabrese, if you really want, and there's a debate on what is mood stabilizer, which I don't want to go at this point of time. But pharmacotherapy is the mainstream of treatment which is there all the time. Now, what are the molecules? I think it's very easy to remember this if you really talk. Lithium, valproate, carbamazepine, oxycarbamazepine. These are the 4 molecules which really have some evidence, but these are quite old if you really. 1980 and 1990 for oxycarbamazepine. Lamotrigine has, as I said, very limited evidence. Atypical antipsychotics from 80s onwards, from the term clozapine, which was defined by Hock and Polanyi, is the one who gave this name to clozapine. There are a host of molecules, and US FDA trials were effective in bipolar. And I'm going to show you the other evidence which has come. The only new molecule which has come in this, I would say, last decade or less than 10 years, which we are going to discuss today. And coming to the bipolar disorders, we keep talking about mood stabilization. The effective maintenance, according to this recent review published in 2018, we have the evidence of monotherapy, and that's why if you see any treatment guidelines, including CANMAT guidelines, and this is probably the authorities who have worked, John Geddes, all the names you hear, as you can see here, Kessing, all these people have summarized in the large meta-analysis that these 5 molecules, lithium and the other mood stabilizers, which includes atypicals, can be used as monotherapy, and that's what systemic review has shown, published in 2018. But coming to the next part, I think this is the best evidence which is more recent in 2022. And what I'm trying to show, I'm sorry, this slide might not show what I want to show, but the best combination evidence base is aripiprazole valproate right on the top. As you can see, the effective line coming more towards left. The next best is, as you can see very clearly, surprisingly, oxcarbamazepine and lithium combination. Lithium and oxcarbamazepine is the second best. And the third, a molecule which we stopped using, SNPN, has the third best results. Here I'm talking about mood stabilizers as evidence in both mania and depression. And the fourth one is olanzapine. I think we use very regularly. This is one molecule which has a very large bit of evidence, both for mania and depression. And finally comes lithium and valproate. If you see CANMAT guidelines, they talk a lot more about that. But then as you go down, lithium is actually 8th position to be a mood stabilizer. Why I'm bringing this? This is based on almost 168,000 patients in the clinical trial. So this is where, and this is published very recently in 2021 by Kishi et al. This is of course a network analysis study. Now I'll come to the one point. I would like to say this. PKC is not a new. Lithium has an anti-PKC action. Valproate has anti-PKC action. But what is new is considering molecules in PKC, and the PKC means, as elaborated, this is protein kinase C pathway. It's a large family like our serotonin, dopamine, etc. And it has multi-neuronal action. So it's not a single action which is important. And it is definitely implicated in mood regulation way back in, you will be surprised, in 1999. And the first clinical trial was done on Rajamahendravaram, though that was a positive trial, that was an open label trial. And none did not consider that as an important point. After this, gradually, clinical drug development research in the PKC pathway started way back in 1990 by a few companies. The current clinical practice, the antidepressants, whatever you use, and the mood stabilizers, whatever you are using, do have some bit of PKC modulation. Remember that. And the disruption of PKC activity is known to be associated in the suicidal patients in the postmortem brain. So we do have evidence long time back. But what is new probably is, now we have in late 90s and early 20s, we have identified a marker, a biomarker in terms of platelet protein kinase C. This is supposed to increase during bipolar mania, and it comes down as the mania comes down. So it's a state-dependent marker. And changes in the PKC is now illness-specific. So this is, again, but Endoxifen story started somewhere, and for a lot of you, like Risperidon's baby is a paliperidone, tamoxifen baby is Endoxifen. The only difference is Endoxifen is an aggressive brain barrier crosser. So it crosses and goes into the brain. It reaches much therapeutic level of the molecule. So how did we go on? I'll just give two snapshot examples. Suicidal attempt, PKC is involved, that's well established in the, between 2001 to 2010, a lot of research, so much so it's now accepted as a marker. And excessive activation of PKC actually impairs cognition. So some part of research started whether it will be useful for reducing the cognitive symptoms in depression on one side and dementia. Going further, the inhibitors of PKCs, a lot of molecules were tried, but Endoxifen is one which won the race. When I say this, for each one successful molecule, at least 20 molecules die as the drug development. Now, over the last decade, inhibitors of PKC are known to stop or reduce the ethanol consumption. So it was considered to be used. PKC pathways are considered to be used for addictions. More recently, in 2016, again, PKC inhibition is known to be associated with both cannabis and morphine. So in summary, the second indication which is likely to be useful is addiction. And third, which I will come to show is, I'll tell the story of the Endoxifen. As I said, I think very simple, I have only 25 minutes to present, so I thought I'd summarize. Endoxifen is just a metabolite, and this is the structure. Launched in 2021, very surprisingly during the COVID time, very silently, and today over 1 lakh prescriptions are going on per month. And this is the real figures in the last 2-3 quarters. The lithium molecule is still growing at 24%. Divalproates or valproate together is growing at 19%. You have the two values, 19 and 12, but Endoxifen did grow because it's a new molecule. It did grow at 237%, it's a very high growth in a way. The reason probably is all psychiatrists are looking for a magic bullet. I'm not here to say that Endoxifen is a magic bullet, but this is a drug which, in this trial, my data, whatever I'm going to present, has already been accepted by US FDA too. Though this is not an US FDA, and I'm involved in the US FDA trial in which right now 36 centers across the United States are undergoing Endoxifen versus placebo, which is a gold standard double-blind trial. Very briefly, the history is, this is what the tamoxifen, and the last you can see in the right corner is Endoxifen. And so from tamoxifen, it goes to, it has one CYP, two D6 metabolism, finally goes to Endoxifen. That's the story, sufficient for you. But what is the effective dose? The effective dose is either a 4 milligram or an 8 milligram. That's which is derived over the trial. So if you want to see the pathway, in 2007 is the first preclinical trials. Animal studies were completed by 2009 to 2011. But phase 1 normal volunteer study, because they allowed for the first time, they wanted to do for many years in a very small sample. Then we went to the phase 2, phase 3, but the most two important seminal studies were done in our country by multi-center trials across the, and then right now it's awaiting an approval into 2023 for US FDA as well. Endoxifen is very easy molecule to give because of its half-life. You can give as a single dose, not metabolized by CYP 450 enzyme system, thus less potential for drug-to-drug interaction. If you want the summary of an Endoxifen phase 2 trial is, they have come at 8 milligrams and 4 milligrams to test, but phase 3 trials, the two seminal trials reported by Ahmad et al. In 2016 and 2016, based on these two large data of our country, our DCGA has given approval in the year 2021 after another trial. These are the summary of the trial. As you see, they compared Endoxifen alone versus valproate, divalproate, and what you see is the graphs, as you can see here, both more or less same. In fact, there was a slight difference of number, Endoxifen being little superior but not statistically different. Like this, as they move further, you can find that remission rate and response rate actually more or less similar. So based on this, and coming to the side effects come in Endoxifen arm, much less than 6%. That was surprising for me also when I initially have gone through, because if there are no side effects, the drug might not act. That's what. Especially for remember, Endoxifen is an anti-cancer drug for breast with a very specific indication in certain breast cancer. I have gone to the research on the breast cancer, and the data very clearly shows this is one molecule which does not have much side effects. Headaches, vomitings, insomnia, restlessness, gastritis. This, and in our clinical trials done in our country, which is published, the more recent one was published in 2020, as you can see. No treatment emergent depression in a 6 months follow-up trial. There were no deaths, no serious significance, but even the side effects is very essential. This is the time when I thought I would do, and with the help of the sponsors, there was a small financial grant, a large multi-centric real-world experience in our day-to-day clinical practice. So we had a few meetings, and these are the large number of participants across this country. I don't need to name each one of them, but I thank them for their contribution. And what did we do? We have done 2 trials. We started way back in November 21. You remember it was introduced in January. I had my initial experience. I took time. I originally wanted to have at least 400 patients into my 400. So we did enrolled in 450. In fact, the total patients enrolled in this trial was 450. There were few dropouts naturally. Today I'm going to present the data of 2 interim analysis of some of them. This is a prospective multi-centric non-interventional study of Endoxifen in the treatment across the bipolar 1 mood spectrum for mania or without depression or with mixed depression. That's what we originally took. But unlike the previous 2 trials, I've done for 42 days so that I'll get a much better understanding of what happened. And the second protocol is all these patients who are willing to go for further 6 months follow-up. Remember, already I've done for 42 days. I want to do for further 6 months so that at least all of us will have some clinical data. Here, as you can see, the patients is a very simple, both sexes, 18 years and older. I did not want to keep a limitation because there's no, considering that bipolar, most bipolar come, and these are the stable bipolar who would present with an acute mania, but they should not have a significant comorbid medical condition. This is my patients. As you can see, the 241 patients I'm presenting the data. Remember, this is only interim analysis. I have completed, till this point of time, the acute 448 patients. So you can see this is roughly a distribution which each one of you can expect. Now, what I have done in the trial is, we have had a protocol, a little flexible protocol, because some of the sites wanted that we can we use concomitant. We are not very comfortable giving Endoxifen alone. So there, in that sites, concomitant medication was given. So there are patients with pure Endoxifen on one side. Remember, it's an open label trial. And these are the other classes of molecules in which the other patients have. And the illness duration, as you can see, is again very variable, but more or less manageable. And this probably is a graph which showed we have done on the assessment of the baseline, the day 4, and 14, 21, and 42. In this sample, roughly about 22 patients dropped out for social reasons and otherwise. But during the trial, as you can see very clearly, the drop started occurring, or the improvement, as you can see if you want to see the YMRS scores, it is started occurring at the 4th day. This result is more or less similar to the 3 studies published at this point of time. Likewise, the YMRS scores change from the baseline to the others. As you can see, the graph is going up, so it's an improvement graph. And roughly at the end of 42 days, 70% of the population studied in the sample achieved remission. Remission criteria we have used is YMRS 8 and less. So on that criteria, the majority have achieved. And YMRS scores, as you can see, have reached baseline. Now I come to the CDI-BP score. During the 42 days, none of them switched to depression, nor had any depressive change during these 42 days. So this is the data. And this is the broad list of side effects which we have encountered. Some of you might be surprised on seeing fever or cellulitis or a hand tremor or something. But remember, in a clinical trial, whatever patient develops new symptoms needs an adverse event. But what is interesting is across this large sample, across these 19 centers, we had only this number of, and nobody had serious adverse events. The uniqueness of this trial is it's a multi-centric Indian trial. It's a good ICH-DCP. All the centers had ethics committee clearance and ethics committee overseeing, and it's real-world patients. But the shortcomings of some of you might comment is it's an open-label trial, but at this point of time I did not venture to go to a double-blind. Maybe tomorrow I might go with another protocol to the company if they are going to give me a financial grant. I would now do a real-world double-blind placebo control if it's possible. I will share with you in the next 3 minutes my experience beyond bipolar Endoxifen. Remember, Endoxifen is approved for bipolar mania and bipolar mixed. I started using, remember, I used most of the things based on whatever evidence we have for PKC. Remember the cognitive improvement. And we had a large number of patients who are in my schizophrenia clinic, treatment resistant, both in symptomatic or negative symptoms. In treatment resistant schizophrenia, I have used in about 28 patients, and in negative symptoms, 35. I would say about 30 to 40% there was an improvement. It's not a dramatic all improvement. Now I'll go to the other important area Most of you know I've been working in dementia for the last 5 years for my PhD. So I have a large sample of dementia, and dementia more often than not, agitation, delusions, nighttime behavior, aggression, hallucination, mania and depression. These are the set of symptoms. I right now have 90 patients for the last 1 year, last 18 months who are on this molecule. 4 milligrams or 8 milligrams. Whoever are responding, I'm keeping, and my response rate is vary between 50 to 60% in this group. I also tried whether the cognition is improving. Remember, I'm not giving just this Endoxifen, I was giving with others. But at the same time, in dementia, what is standard treatment, they were still getting. So there was an improvement of cognition. And a few patients who used to complain of cognitive deficit, a very small sample though, I can say it's only 14 cognitive symptoms and assessed cognitively. I tried using lithium along with Endoxifen. It led to some improvement in at least half of the patient. And finally, there is a large population which I have used in the last, again, more than 18 months. Alcohol abuse patients about 60, cannabis abuse 48. These two groups did have a primary bipolar disorder diagnosis. Majority of these patients, by majority almost. So it's a comorbid mania or bipolar with these two. In this, they still continue to use. And there is another interesting group which I have. I have about 28 pathological gambling patients who are on divalproate and endoxifen. In the last 18 months, 12 of them completed 1 year. So they practically stopped because the only other drug they are receiving is divalproate and endoxifen. The other indications which are used is in the externalizing behavior. Remember again, this is evidence-based evidence, where aggression, mood swings are the predominant symptoms I have used, with definitely some promising results. Especially I think wherever there is an aggression and impulsivity, this molecule might work, that's my experience. And externalizing, as I said, the pathological gambling, I have to update, it's 28 now. Especially the pathological betting, most of these patients who are in this have lost nothing less than, lowest they lost is 50 lakhs in the last 1 year. Maximum was 6 crores in one patient who has not gone for gambling in the last 9 months. So this is one area. And the mixed episode, I had mixed results. 55 patients. Most of these patients are with divalproate and endoxifen. And about 30 to 40% respond. So I would like to close my summary with my little experience. It's a good molecule. It's a large data has shown efficacy and safety. From the side effects point of view, it actually is better than the other mood stabilizers which we discussed. Matches my study, whatever we have done, matches with the clinical evidence published already. Less side effects, no metabolic, no prolactin, no PCOD, no hair loss, no EPS. But I would like to say, with my large data, whatever we are following very closely with all the rating scales, less than 2 to 3% seem to have menstrual problems. And then we find that group is between 15 to 30. And most have PCOD at the even before, because it's a routine in my clinic that once a bipolar comes, I do at least a few assessments. Prolactin is one, thyroid is one, PCOD assessment, especially for young girls. The majority had some kind of PCOD. In some it deteriorated. I can't say whether it's due to endoxifen or not, but remember that can be one. So I close. It's far better to live like a tiger for a day than to live like a jackal for 100 years. All of us sitting here are looking for a molecule which would be like a tiger. I'm not saying endoxifen is a tiger as yet. I'm not that much biased. I'm looking for evidence. Just in the morning, I had my discussion with my elder brother, Sudhakar, sitting here. He asked me one question. Prasad, ఇది మందు నిజంగా పనిచేస్తుందంటావా? I explained, if it doesn't work, why will I write or why will the patient continue? He said, no, I'm not doubting that. I said, in your evidence. Evidence is there. Thank you, brother, for asking that wonderful question. What I'm looking forwards, I'm definitely looking forwards for long-term exposure. Right now, the data is about published data. My paper, one of the paper will be published probably in the next 6 months. We have only 6 months. Now we need a long-term, clear evidence for efficacy beyond bipolar in all the indications I have tried. I've tried the logic is the PKC wherever it is inclinated, I tried. There was some bit of success, probably for each one of you. It's worth trying and gain some experience. Thank you, ladies and gentlemen, for patiently listening. Thank you, Rama Reddy garu, for inviting me. And thank you each one of you for staying. Though I'm the last batsman, I'm happy that there are 2 other batsmen who will join me very soon to contribute to their knowledge. It's my time to invite Indra Vishal to the dais and over to the chairperson because Vishal would probably guide you through some questions where 3 of us will answer.
I invite Dr. Rajesh also onto the dais as the other panelist. That will complete the 4 panelists on the dais. I know we are running a little late and I'll try to keep it short and sweet. So we have 4 panelists. There are about 8 to 10 interesting questions I wanted to pose to them, and each of them can take about 2 minutes for each question so that we can cover more questions. And maybe towards the end, if there is time, we can take a couple of questions from the audience. This is a new kid on the block, and one of the questions that comes to the mind, when you think of Endoxifen, which patients come to your mind? Dr. Rajamahendravaram, because you've been using it a lot, can I know from you what kind of patient profile you are looking at when you think of Endoxifen?
Initially, we started in patients with manic episodes, and then we had good experience, so we continue to use it. Any new molecule in psychiatry is welcome. And we always look for patients' improvement with drug and less side effects. Nowadays, though the lithium is a gold standard, we have concerns about long-term efficacy and long-term side effects on kidney and other areas. And in acute state also there is a risk of toxicity if the patient is not very compliant with our advice. So here the response to the molecule is good. So the first thing is bipolar disorder, manic state. And once we got confidence in treating manic patients, we started using this molecule in mixed states, and the response is good. As you know, the lithium is not the drug of choice there, and a lot of patients, especially females, they cannot tolerate divalproate, where they have many side effects, hair fall, and then weight gain, edema feet, several side effects are there. So this is well tolerated, and not many adverse effects have been reported, and there are patients who are on months on this and who have not gained any weight. So that is main advantage. And we always thought antipsychotics are equally effective in controlling mania. And it doesn't seem so in some patients. There are always exceptions. And I had one patient who had manic episode while she was pregnant, and she was on haloperidol by the time she came to me. And I continued the same because we couldn't afford to start any other mood stabilizer. And there is a lot of experience with haloperidol, which doesn't produce many teratogenic side effects. And she continued to remain manic after 6 months, and after delivery, 2 months after delivery, she came back to me in the same state. Family somewhat tolerated, and then we started Endoxifen for her, and within 2 weeks, she has improved like magic. So there is a good experience with Endoxifen in several patients of manic episode. Now in mixed states, but I have yet to try these patients with gambling, internet addiction, and other drug addiction patients.
Dr. Rajesh, one question to you as an extension of what Dr. Krishna Mohan.
Patient who is having bipolar mood disorder since 7 years, a female patient, and she has conceived for the first time. And as soon as she conceived, she was on lithium before conceiving. So she's well educated, well informed. So she was having apprehension about continuing lithium. So she consulted me, and I told her, naturally lithium cannot be good once a patient conceives. So I asked her to stop lithium. And she was on risperidone also. So I asked her to continue risperidone and started Endoxifen. And she continued Endoxifen throughout pregnancy, whole 9 months. And along with Endoxifen, she didn't want to continue risperidone because she was having sedation. She was also, I also gave quetiapine because she had a brief episode of psychosis after in the 3rd month or 4th month of pregnancy. So I had to admit her for 2 days. And then I gave her aripiprazole and quetiapine and then Endoxifen. After that, she stopped risperidone because she was having some concerns. Again, as I told you, she's well informed. So I continued aripiprazole and Endoxifen throughout pregnancy, and she delivered a healthy baby. So this is an experience which I never thought that Endoxifen can be continued during pregnancy because it's a metabolite of tamoxifen, and I was having some concerns about it. So that's what I wanted to share. And the other question which you asked, it's the same thing which other speakers have mentioned. I always, I started giving Endoxifen to bipolar mood disorder primarily, and I have many number of patients on bipolar on Endoxifen, but not as a monotherapy. Initially, at least in the initial 1 to 2 weeks, I have to give other drugs like antipsychotics, other mood stabilizers. But I felt Endoxifen is very good on a long-term basis, but as a maintenance therapy for bipolar. I have quite a good number of patients who are on Endoxifen, and they have not discontinued. And one good thing is, no one has relapsed. And all the patients who are on Endoxifen at present, for bipolar, they are in the remission, and they are not having much side effects, which you see with other mood stabilizers.
Thank you, Dr. Rajesh. Now may I ask a question to Dr. Sudhakar Karri, molecule lithium. But can we look at Endoxifen in these patients where lithium is challenging? Could be because of side effects, could be because of so many other reasons like Rajesh mentioned, pregnancy, etc. What do you see, sir? What do you think?
Lithium had gone down drastically. Because, I don't know, the new generation is so afraid of lithium, they rather prefer valproate to lithium. That is the number one point. As far as lithium monotherapy is concerned, definitely lithium, at least because we have a wide exposure to it, a very long experience with the molecule, we definitely feel comfortable with lithium. But when there are certain challenging instances to continue with lithium, definitely we will think of other options. Maybe because now there is a new molecule which is comparatively safe, definitely I do consider Endoxifen as a choice. But again, this comes with certain riders. Actually, that's what I was asking Dr. Prasad in the morning. Like, first rider is, most of the times, acute manic episodes have got a fairly good chance of self-limiting. Most of the manic episodes do not last beyond 12 weeks. And we say that this particular molecule itself takes nearly 3 weeks to show some impact. Then, can we really consider that Endoxifen itself is giving relief, or is it part of a natural remission that is happening in a manic episode? So this is one thing which has to be clarified. Second thing is, most of the times in practice, because we are not doing a RCT, what happens is we do use certain concomitant medication, especially atypical antipsychotics. And when there are so many molecules available for you, we try to minimize the side effects by prescribing more than one molecule, so naturally polypharmacy becomes a rule. So whether the drugs which we are giving along with Endoxifen, probably that is helping Endoxifen to exert a bigger effect than what exactly offers as a monotherapy? That's another question to be answered. Actually, for that, in some of the meetings which have been organized by ITAS for Jonalka promotion, I was asking them, you charge most of the senior practitioners or the practitioners who are interested in trying this drug, some sort of a organized way of prescriptions, so that we can collect a lot of data, generate data, document it, and present it in a bigger conference so that we can share our experience. Definitely, original answer to the question is, because there is an alternative available, we'll definitely try. If you say, is it monotherapy? I'm doubtful.
Sure, sir. Sir, thank you for your insight. It's always nice to have somebody playing the devil's advocate, so we all...
Right individually. Right now, 42% of my patients are only on Endoxifen. Initially, it was valproate with this with atypical too. In my first, you can say my own learning curve. So the second point is, it's something like, which is first, egg or chicken. Unless you use, you won't get confident. And as you correctly said, it is the patient's, family's anxiety on one side, and your own anxiety, the treating psychiatrist's anxiety to quickly make him all right. I can say just one statement for all of us to accept. I'm sure everyone will accept. None of the medicines will make 100% remission, for sure, for variety of reasons, because patient doesn't complain. But at the same time, I think unless you use Endoxifen alone in certain indications, especially bipolar mania, pure bipolar mania, as he correctly said, after 3 months, 4 months, then that's the time when
Sir, in continuation with that, one more question to Dr. David. So, we usually start it in acute mania, but is it something that can be looked up as a molecule that can be used for maintenance treatment as well?
Yeah, why not? I also look to use it as a prophylactic also, if it is effective. It's not just for acute state, it's for my maintenance till that 4 or 6 months are over, and then if there is a data which supports its efficacy as a prophylactic in recurrence, prevents recurrence, I do consider this molecule. Only concern for clinicians or patients is cost. Otherwise, molecule-wise, it's good.
In addition to what you said, sir, one point to be added is generally any molecule that has been effective in acute stage is something that is good for maintenance as well. So by that analogy, though we don't have trials at this time, I think by that analogy, it's something that we could continue to use in the long term as well. The next question again to...
Dr. Vishal,
yes,
a caveat for that.
Please.
Because of the cost, I'm afraid whether in Indian setup, whether we can use it as a prophylaxis for years together.
Totally agree.
Yeah, we hope it comes down, price comes down. Like paliperidone price has come down. Similarly, at least for patients who cannot tolerate other drugs. There are several patients who cannot tolerate lithium, who cannot tolerate valproate, and who cannot tolerate several antipsychotics too.
Totally agree. I think price is one limiting factor in the use of Endoxifen at this time. But as Sir was pointing out, there might always be a niche group of people who can afford and who can benefit from a molecule which has lesser side effects. Again, another question in continuation with this to Dr. Rajesh. Because this molecule is pronounced to have lesser side effects, say like sedation, tremors, which are seen with your classical mood stabilizers, lithium valproate, do you think it increases your preference for using it in working class patients, the younger patients who could be very vulnerable and could have problems if they have even minor side effects?
Yeah, absolutely, because the very point that it doesn't have much side effects, that is the reason why I got attracted to this molecule basically. And young population is the population which basically suffers from bipolar mood disorder. So as we all know, valproate causes tremors, lithium causes tremors, valproate also causes weight gain, sedation. So a lot of other side effects which young population is always worried about. And so far in my experience, I never saw all these side effects which we associate with lithium and sodium and divertics. So it has encouraged me to basically prescribe this to this young population who is suffering from bipolar disorder.
Sure. Next question to Dr. Prasad. Sir, what are the challenges in treating female bipolar disorder patients with current treatment options? You highlighted some, so don't want the repetition of that, but can you see Endoxifen as some kind of a newer hope in bipolar patients, especially with the caveat that there is some connection and fear that tamoxifen, Endoxifen, some reproductive changes, some things on the carcinogenic potentials and all that. So can you allay our fears in this context?
I think that's a very interesting question. First of all, this molecule also works in certain estrogen receptors. Incidentally, they are not the estrogen receptors involved with the uterus. They are involved with the breast. My own experience with working with female is, in general, the reports of weight gain, hair loss, hirsutism, all connected with the PCOD on one side. The other things is definite reduction of polyforms that happened over the period of time. I mean, it's happening, it's a present continuous, I would say. Third thing is, women, it's far more easy for two reasons: that no sedation, no tremor, no thing. It affects their day-to-day activities also improve. There are these 3, 4, and fourth one, I would say, if they are in a fertility period, though the data, I mean, Rajesh, I told Rajesh to report that case because that is the first case, it will be going to be the first case, as we know. But we need a larger amount of data for the pregnancy. That excluding. Safety point of view, Endoxifen seems to have a much better umbrella at this point in time. As I said, 2 to 3% of women are having some, but because in my own data, right, clean data, obviously because we do there is worsening of PCOD. Now whether you attribute this to this molecule or not, then it needs a much more larger study. But I think I would be very comfortable with those side effects. Hair loss, PCOD, weight gain, and of course the other metabolic symptoms, metabolic side effects with the other atypicals. I would personally prefer a little more on Endoxifen than others.
This question to, again, Dr. Krishna Mohan, because he also sees a lot of dual diagnosis patients. So, sir, have you tried, and what is your experience when there is a comorbid psychiatric condition or a dual diagnosis, a comorbid substance use? How have been the results? Any concerns on that front?
Sorry, I didn't use in bipolar disorder with substance abuse. I didn't try. But as there are case reports from Dr. Prasad and also like it has been effective in patients who were unstable mood is been reported, and also where addiction is a problem. You can definitely try this, but I don't have any personal experience with bipolar plus substance abuse, but I do have experience in mixed states. Where I found it very effective.
Dr. Rajesh wanted to add a point on dual diagnosis.
As I'm running a rehab center and we admit a lot of substance use and substance dependence patients, I have tried in quite a good number of substance dependence patients, and so far the results are quite encouraging.
Looks like Endoxifen, and I agree with Dr. Rajesh, we have a huge group of de-addiction patients who are very high on impulsivity. It looks like on that cluster, leaving the diagnostic label apart, it could be bipolar, it could be borderline personality, it could be some drug abuse, but the cluster called impulsivity, where the prefrontal cortex is involved, that looks like one niche area where Endoxifen seems to have a decent role to play, and I concur with Dr. Rajesh's experience in that area. One last question, any other indications where you have tried Endoxifen beyond bipolar mania and mixed episodes? Each panelist can give one indication if they have tried it in initially, Intas marketed it only for bipolar disorder. And I was wondering, bipolar we have reasonable options. So initial 1 year, I think probably they also didn't know where exactly this molecule was going, but now a lot of us use it in indications beyond bipolar, And so I request our esteemed panelists to give one indication probably, which is not bipolar, where they have found good use for this molecule.
I think I will start first because my experience with this patient had been quite dramatic in the practitioner point of view also, because I had been seeing this patient right from the age of 10 years. Initially he came with a lot of obsessive symptoms which we commonly see in adults and males. And there was fairly a loading in the family. There was one history of suicide, and then probably the father had a personality disorder amounting to maybe cyclothymia. And then there was one distant second degree cousin who had been treated by me for paranoid schizophrenia. And this individual, as he grew up, right now he is about 26-year-old, and as he grew up, the diagnosis kept on changing. And when I last saw him after a gap of nearly 5 years, this patient was diagnosed as a paranoid schizophrenia by enhanced people and was admitted or administered ECTs and all that. But I actually had gone through all the records, and from my memory I reviewed the diagnosis. I thought it was probably a borderline personality disorder with maybe micropsychotic episodes happening in between. And I apparently did not have any choice for this patient because every drug had been tried, and the patient unfortunately knows the trade names of all the drugs. So I was forced to try something new. So luckily it struck my mind that I should try this molecule and see for 15 days time. And actually this happened nearly 2 months back. I shared this experience with Dr. Margaret and other people. And this man, within 15 days, his aggression had gone down. His psychotic symptoms have gone down. Of course, as I said, it was probably a micropsychotic episode. So I don't really ascribe the effect to Endoxifen proper. But his mood changes and those very superficial emotions, those outbursts have gone down drastically. The patient became more cooperative. And right now I think it's about 6 weeks now, still patient is busy, he is manageable. I think this is one case where probably it is definitely not a bipolar disorder, not definitely a schizophrenia. Still I hold on to my original diagnosis of a borderline personality disorder, where probably this is one which we can check.
That's a very interesting indication. That's a very difficult diagnosis to treat.
Thank you, Vishal, for asking this one. I actually thought of saying about schizoaffective disorder. I used in few patients with schizoaffective disorder, and they did respond well. One patient was very on irregular medication and continued to have problems while on haloperidol and other drugs. But she was given this Endoxifen and antipsychotic. She left for state for 6 months. They continued for 6 months, and then when she returned, she stayed. So it is effective in schizoaffective also.
Yeah, that's a very good question, and as I already mentioned, I am using one substance use disorders. Pure substance use disorder is not comorbid with bipolar.
Sir, I would like to just say the one which I didn't touch in my presentation, which I am using. I have about 12, 14 to 18 who have come late for ADHD, but who have comorbid other child psychiatric diagnoses. To me, they are the emerging borderlines. When I say emerging, they do not really fit into the typical borderline personality. But to summarize, in a broad sense, this molecule works wherever there is an aggression, activity. Alcohol, comorbid alcohol can, in fact, it's better in cannabis than alcohol for some reason, I don't know why. In my patients, it was evidence-based. And pathological gambling, as I said, 28 patients, I slowly am adding, whoever comes to pathological gambling, and somehow they are drifting to me. So these 5 indications apart, I think suicidal area, that is one area, because PKC, if you go to the literature, you get a lot more data on that. I have one interesting patient to just close today. She's a young girl, 19-year-old girl. She's with me since her 14 years. Her only symptom is she would just attempt suicide. Many times, no reason at all, no reason. She's right now on Endoxifen, 8 milligrams per day alone, no antidepressant, because clinically she doesn't qualify for any. Last 9 months, no attempt. Because prior to that, every 2.5 months there will be one kind of an attempt. So this, probably we need to take this molecule much further with this base. I think it should remember.
Just to add to what the special indications have been mentioned, we run child diabetes clinics and sometimes we see kids with severe externalizing problems, even below 10 years. Because I know for sure that it's a safe molecule and all the speakers have pointed to that. So from our use, we know that we are not going to do any harm. So we tried with half a tablet of 8 and then, some of the kids have shown some improvement, some of the kids have not improved, but at least in the days when we are craving for new molecules, because some of our molecules cause a lot of side effects, this one is like the new kid on the block, which has very good safety profile. So I would think all of us should try it for ourselves with our patients and see for us ourselves how the experience is. I was avoiding this molecule initially because of the cost factors, but once I started using it, I am sure there is a niche population which benefits from the safety profile and the effectiveness of a molecule like Endoxifen. With that, I think we are already running very late. So I thank all the patient listeners here and I thank Intas Pharma for organizing this symposium panel discussion and all the panelists who have done a wonderful job trying to give us the nuts and bolts of this new molecule. Thank you once again.